I'm going to just make a few remarks, and then we'll just open this up for discussion and questions. The main thing that I'll be talking about is primary care and role of buprenorphine treatment in primary care. But what I understand is that this breakout was supposed to focus on both integrating addiction treatment into primary care, but also coordinating care across different systems. So please ask questions about anything related to that. With regard to treatment of opioid addiction within primary care, something that I do a fair amount of is talking to primary care doctors about our opioid crisis. And I feel bad for primary care docs. Do we have any primary care docs in the room? I feel bad for you guys. You were, well, I mean, it's really hard to be in primary care regardless of the opioid problem. But with regard to the opioid problem, primary care docs got pressure to prescribe opioids aggressively. We were all really hearing that opioids needed to be prescribed more for chronic pain, and we heard it from our professional societies, American College of Physicians. We heard it from the pain organizations. We heard it from our state medical boards here in California. Doctors were mandated to take pain education that encouraged opioid prescribing. Hospitals, Joint Commission, from every different direction, we were being told that the proper compassionate way to treat just about any complaint of pain was with an opioid prescription. And now there's a different message, and this conference is sponsored by the California, one of the co-sponsors is the California Department of Public Health, and the California Healthcare Foundation, and the Surgeon General just sent a letter out the other day, and now suddenly we're hearing that we've been overprescribing opioids and we need to really rein it in. And so I can imagine some primary care docs out there saying, can't you all make up your mind? Primary care docs in some of the clinics, particularly safety net clinics, that where there was this aggressive push to prescribe opioids, and primary care docs who wound up with a large panel of patients on chronic opioids would pretty quickly begin to hate doing this work. Many primary care doctors, it's the bane of their existence is the chronic pain patient on opioids because they're difficult to work with, they're not really getting better. If you've been doing a lot of this, you may have had patients who died of overdoses, and it's primary care docs in general, my experience has been that they hate doing opioids for chronic pain. And I know some FQHCs and some clinics have found a single doctor or a nurse practitioner, and they're just like, you take them all, because they just don't want these patients. And when I speak with primary care docs about treating opioid addiction with buprenorphine, many of the response I'll often get, and sometimes people even are pretty explicit about it, it's like, are you kidding? If I hated working with the chronic pain patient on opioids, why would I want to take a course in treating opioid addiction with buprenorphine? I would be even more miserable treating those patients. Those are the real addicts, and wow, boy, I would hate that. And what's interesting is that for primary care docs who have taken a crack at it, who've gotten their waiver to prescribe buprenorphine and start treating opioid addiction with buprenorphine, what you will find out is they generally really like that experience. They find it very rewarding. Are there any primary care docs in the room who treat opioid addiction with buprenorphine? Okay, would you guys mind sharing? What do you think about it, and how would you compare it to having treated chronic pain with opioids?
So much better. Wait, they gotta get what are...
Oh, hold on, wait. And by the way, these folks are not plants. I did not put them in the audience.
My name is Dawn Harbatkin. I'm at Lion Martin Health Services in San Francisco. I reluctantly started treating opiate addiction. We needed somebody to do it when the one provider who did left and I got stuck. And it's been the most rewarding part of what I do. Patients come and they're motivated and they do better. They end up more stable. It isn't an argument and a fight every single time over what the medication is going to be. It is what it is and it works.
Thank you. I think we had another, oh yeah.
Yeah, I'm from Humboldt. We started doing buprenorphine for heroin addicts when it first became, legal for office-based treatment because there's no methadone program anywhere in Humboldt. People had to go to Santa Rosa, and people were begging. So we started. I've been in Humboldt County since 1978, and I always say this, I don't know, there have only been a couple of things that are like that in medicine where you do something that makes such a huge difference. I mean, penicillin for pneumonia is pretty good, and those clot buster drugs for heart attacks were good, but I mean, as far as it's just remarkable to have someone who's in total disarray, and then a week later they're shaved and looking for a job, and it's just a remarkable thing.
Yeah.
So,
Yeah.
and in our experience too, once we get a lot of our doctors were really reluctant, but now as they watch and see it go, we have more and more. I think half of the doctors in our clinic system are prescribing now, and they all find it to be a rewarding thing to do.
Thank you. And I think we had a couple other hands.
My name is Nanad Atali. I practice in Napa County with Ole Health. And I got my waiver, I think, 3 years ago. And for the first year, I did nothing with it because I was too scared. And I just sat on the waiver. And I'm the only one, to my knowledge, in Napa County that's open and taking patients. So it's a lot of pressure. But I just decided I picked one patient who was particularly challenging and struggling. And I told him explicitly, look, you're the first person that I'm prescribing this medication. We're going to try this together. And it worked. He's doing extremely well. And now I have about 10 patients, and I agree. It's not as hard as it seemed at first, and it's very rewarding.
And did you previously do chronic pain treatment with opioids?
Yes, by default.
And how would you compare the experience?
I think it's totally different. I don't think it even feels the same to treat people on buprenorphine who have addiction versus treating the chronic pain patients. If anything, it's made my ability to treat patients with chronic pain on opioids easier because I know I have a way out. If it ever gets to the point where I feel like they're unmanageable, I'll offer them Suboxone and say, like, look, this is what needs to happen, or I can't continue to help you. And it's definitely felt easier in that sense.
And have you had pain patients that you've switched over report worsening or improvement in their pain, or the same? I mean, what's been their experience with their pain problems after switching them?
I think it's been mixed. I think I haven't had that many that I've been able to convince to go from opioids to buprenorphine. I think one did tell me that his pain was not managed as well and ended up going back on opioids, but it's mostly been the people that have been using heroin or buying prescription drugs on the street.
Okay.
I think Dr. Hunter has another comment on that.
Well, yeah, I mean, I have a young colleague who just did a study for a leadership program he's in. I think he's specifically looking for chronic pain patients on high dose of opioids and who are dissatisfied, doctors are dissatisfied, whatever. He had 25 patients. His data was striking and remarkable. I mean, I don't know if it's because he's charismatic or what, but the pain scores were better, the PHQ-9 scores were better, the quality of life scores were better. I mean, it was just, the average pain went from, the question is, what was your average pain last week? I think it was 7 to 8, which on their scale was have a hard time getting out of bed, don't leave the house, to like 3. And this is from high-dose opioids to, morphine and stuff, to buprenorphine. It was just remarkably better.
So that experience that you're reporting, we have quite a bit of anecdote out there. Not enough good papers published on this yet, but anecdotally, the pain patients who are switched over to buprenorphine have very significant improvements in their function, in their quality of life, and sometimes even improvements in their pain, but rarely do you see a worsening of pain after being put on buprenorphine. And so I think we've got about 10 to 12 million Americans who have been put on long-term opioids, and the best available evidence is telling us that that population of chronic pain patients on long-term opioids is not doing well. They've had declines in their level of function and significant pain despite being on chronic opioids. And this is a population that we're struggling with, especially as prescribers figure out that we can't continue to do this. And I do think for that population, buprenorphine is going to be one of our primary options. One problem, though, and I don't know if anyone here has encountered this, is that for some of the pharmacy benefit managers, if people's pharmacy benefit, if you want to prescribe them Suboxone, there's a prior authorization where the pharmacy benefit manager wants the prescriber to indicate whether or not the patient has a diagnosis of opioid use disorder or opioid dependence. And if the answer to that is no, they won't pay for the prescription because it's technically off-label for pain. And so that's one of the big challenges. I've heard that Medi-Cal does not have prior authorization. So you could potentially do off-label buprenorphine for someone, for a pain patient who you don't want to put the opioid use disorder label on. But that is one of the bigger barriers. So one of the things I was hoping we could do is really just open this up to discussion where people in the room here can share some of their experiences or some of their challenges and any questions that they've got on in trying to integrate care.
And I'll also add that invitation goes out to the folks who are listening remotely to this. If you have questions, please type them into the chat room and we'll pick them up.
Hi, I am an addictions nurse. I've worked in many settings with buprenorphine. I spent 7 years in the VA working with young acute trauma, war vets, and heroin addiction. And there's this very clear trend of trauma and heroin, especially. Often if you're looking at heroin, you're also looking at some kind of childhood trauma or adult trauma, very prominent feature. In fact, in our intakes, we use the ACE, the Adverse Childhood Experiences. Every one of our recent intakes are 7 or higher. And so what that presents, especially in primary care setting, is some pretty acute mental health needs. Getting the patient stable on the buprenorphine is one piece. Being able to help them sustain sobriety with that support is often a scramble.
Mm-hmm. Yeah, so I appreciate the point. And we do know that, and it's not just opioid addiction where co-occurring mental health problems can play a significant role, and a past history of trauma does seem to be a risk factor for the development of opioid addiction, a very significant risk factor. I will say, though, that when we think about opioid addiction, there are patients who can be higher risk. For example, a patient with a history of trauma, or a patient with a previous history of a drug or alcohol problem, or a patient with depression. If you give them an opioid for their pain and they're feeling much better now on that opioid, that's going to be someone who's going to be more likely to repeat the use. So even though you've got all of these different risk factors for the development of opioid addiction, the common pathway is the repeated use of the drug. So if you're repeating your use of the drug because you're self-medicating in some way, dysphoric feelings related to trauma or depression, or your repeated use is because a doctor said take 2 pills in the morning, or puts you on the opioids, at the end of the day, the common pathway is the repeated use, and it's the repeated use of the drug that's ultimately resulting in the development of opioid addiction. In patients who have addiction and a co-occurring mental health problem, there's pretty strong evidence that you'll have better outcomes if you address that co-occurring problem. But addiction is not unique. Other chronic medical problems as well, if you address the co-occurring mental health problem, you get better outcomes in diabetes or better outcomes in HIV. So, you know, I do worry that you might have some primary care settings that would say, oh, we can't do addiction here because we're not equipped to address the co-occurring mental health problems. And of course, if you have the ability to address on-site under the same roof, co-located mental health services, that's terrific. But you still certainly should be doing this, even if it means trying to coordinate care with some other organization. The other thing I would point out, and if those of you who might have been in the last session I just had, I made a point about, I compared treating opioid addiction with medicine to treating HIV with antiretroviral therapy. And the point being that we know that with HIV infection, that if you address the patient's psychosocial needs, if you give that patient counseling and support, the HIV patients have better outcomes. You see that their CD4 count goes up. You see that their viral load goes down. Common pathway being improved adherence to their antiretroviral therapy. One of the things you don't see with HIV that you do see with opioid addiction is that you see with opioid addiction some treatment settings that will refuse to treat a patient's opioid addiction unless the patient agrees to participate in an intensive outpatient program, unless they're really going to comply with the psychosocial treatment. We'll sometimes say to that patient, you don't get the meds. You don't get to see the doctor unless you're going to see the social worker. And we don't do that with HIV infection, even though we know we get better outcomes if we address those needs. So I think it's a really important factor, but I don't think we should have primary care settings saying, you know, if we can't do counseling here under our roof, we're not going to do opioid addiction treatment. I don't know if that answers your question.
Yeah, hi, I'm Dr. Jean Marsters, both with the California Society of Addiction Medicine and also Lifelong Medical Center in the East Bay. We are going to be implementing a system of medication-assisted treatment in our primary care clinics. So I'll re-ask my question from the other session this afternoon, which is, how would you recommend us to approach protecting patients' privacy and more private behavioral health and also addiction-related medical records, and at the same time trying to maintain a unified medical record, both internally but also with respect to us referring patients out to physical therapy or referring them out to acupuncture, not divulging what the patients might consider and what the state considers more private information. So the intersection between primary care clinic delivery, 42 CFR, you have any recommendations about how to not activate 42 CFR, but instead, have a unified medical record and yet provide adequate privacy protection for patients?
Yeah, that's a very good question, and you did ask me that in the last session, and I punted because this was the session more on that topic, but I think part of me was hoping you wouldn't show up here and ask the question, because it's a very complicated question, and I don't have a good answer. There's certainly experience with this, a lot of experience in the mental health area. And so, for example, you have healthcare systems where there might be a mental health hospital with a psychiatry department and a primary care department and a common electronic health record. And there are systems that have handled this differently. Some which have made the decision that we're all going to share a common record, and others that have put a firewall so that outside of mental health, no one really knows what's sort of blocked off. And some of this is based on the interpretation of 42 CFR by that health system's general counsel. And I think lawyers are going to have a lot of say in this. I think that patients get better care when we can communicate as freely as possible. And I think that we're moving in a direction with addiction where the condition is becoming less stigmatized. To some extent, and I don't know if silver lining is the right word, because it's hard to apply to say that there's a silver lining in our opioid addiction epidemic since it's such a disaster. But something that we are seeing now that we have an addiction epidemic affecting mainstream white America is a lessening of the stigma associated with addiction. When you had addiction hitting inner city communities very hard, this whole notion of an addict, which there really is no such thing as an addict. There are people who have addiction, but to the extent that there are these people out there who are just kind of maybe born bad and all they want to do is, have fun taking drugs and committing crimes all day long, those addicts, that there really is no such thing. And it's becoming a lot clearer, I think, to policymakers in general and to the public in general that there may not be such a thing as an addict. There are people with addiction now that it's affecting the mainstream America. Certainly, if you, even conservative politicians, when you hear them talking about the opioid crisis today, they all start off the same way. They start off by saying, we can't arrest our way out of this. You didn't hear that during the crack cocaine epidemic. What we got was a law enforcement approach. You got the exact opposite. We need to crack down on these drugs and put more people in jail. And so this is sort of a long-winded response, but I think that it's very difficult to navigate this. I think that the way to do this is in a direction of trying to share as much information as possible, and I understand the risks associated with that. And I think as a society, we're moving in a direction where there's less stigma and where we might at one point be at a place where opioid addiction is seen as any other medical problem, and therefore we wouldn't even be having this conversation.
I just want to speak to that. This is Catherine here from the California Healthcare Foundation. And on that particular question of how to handle medical records of buprenorphine in primary care, we are doing a little bit of work to try and publish something that gives some legal opinion, obviously with plenty of caveats on it. So that'll be forthcoming. We have a question over here, I think, and then we're going to go to a few from the phone.
And I think we had a question in the back.
Okay, great.
Yeah, Art Davidson. I'm Deputy Director for Substance Use Disorders and Treatment in Mendocino County. And that whole question about the electronic health record, that's a work in progress. I did want to say one of the really great things, though, of integrating services is we actually have a memorandum of understanding that moving forward with our mental health services. And so we're, drug and alcohol and mental health, co-occurring disorders should be treated concurrently at onset of treatment. Hello, it's been so separate for so long, so I'm so happy that finally they're getting a whole system of care, and then including the clinics in that to give a full, holistic approach and working with these people who are not addicts. I would say probably the biggest challenge we're having right now, you touched on it a little bit in the last breakout session, was I'm finding, for example, in our drug court programs, there's this Right now, it stands that they don't want anybody in the drug court programs, this is just in our county, that are on Suboxone or any kind of chronic pain medications. There's the issue of, the random UA testing and how are we going to, establish they're taking the Suboxone at a certain level, the therapeutic levels. How do we measure that? How about those that aren't in these systems and they're required to have clean testing? How do we work that? But there's also the bias of even within treatment, and I think we've had to change the culture around that. Oh, we're in abstinence. Are you kidding me? Let's do what works. There's people's lives at stake. Let's make the choice. Let's create treatment options. Have it individualized, client, strength-based, client-centered treatment. Let them have their recovery and get out of their process, and support them with these other options. So, but this whole thing with the drug court, it's like a block there. There's still those. Part of our drug court team, of course, is probation, the judges. We have the DA, and there's still this mindset of they need to go to jail.
I appreciate the comment. It's a big problem, and you do have drug courts that are ideologically opposed to buprenorphine or methadone, and embracing Vivitrol, which is concerning because when you think about extended-release naltrexone, may be an appropriate option for a patient with a mild opioid use disorder who hasn't been addicted for very long, or for a patient with an opioid use disorder that's been in remission. Maybe they've been stable for a while on buprenorphine or methadone. But when you think about the average patient with opioid addiction caught up in the criminal justice system, they're more likely to be a heroin injector with more severe opioid use disorder and more likely to be a good candidate for buprenorphine or methadone. And yet you've got the court sort of very enthusiastic about Vivitrol, and in some cases judges mandating that a patient get a Vivitrol injection. I'm the chief medical officer of Phoenix House, and we've got programs in Southern California. In Orange County, the county has money for us to put patients on Vivitrol, and not only do they have money for the drug, they'll pay us I think like $1,000 for each patient we administer buprenorphine to, which of course had the people operating the program saying, "Oh, look, let's do a lot of Vivitrol." And I looked obviously at the patients that we're treating, and I said, these are not great candidates, but there's not a single penny for us to try and get these patients on the medicines that would help save their lives and even reduce criminal recidivism, which is something you would think that the court system would be interested in.
And that's great, right? Put them on Vivitrol, and then they have a relapse, and we're setting them up to basically die and overdose. So that's a work in progress, but what it involves is changing a culture. So anyway, thank you.
Thanks.
So I'm glad you went first, because I work in the district attorney's office, and we oversee our drug court in our local rural county. Plumas County. So we're number 1 or 2 in opioid overdoses within the state. Yay us. And we're trying to figure out how we address those situations. So my question is coming from the criminal justice point of view, and our judge and our district attorney are on board with trying to implement some sort of MAT protocol. But for us, as discussed in the last session, we have a high turnover of treatment providers. We have highly unstable departments and department heads regularly. So how do we coordinate these treatment options and make sure that we are doing this with some fidelity, as well as being able to make sure that we're treating our participants at the highest level possible without potentially violating any of their confidentialities, but also making sure that we are taking public safety into consideration. So how do we do that across these systems?
It's a really good question, and I talked a bit, and we're hearing about the ideological bias, but you can have drug courts where the judge and the the drug court staff get it, but then they may not have the resources in their community, and drug courts don't usually provide treatment. They work with treatment providers, and if the available treatment providers aren't offering it, that's obviously a problem. And I don't have a good answer, but I think that you should know that many of the treatment providers are dependent on the referrals from you. You've got a lot, as a major referral source, they depend on drug courts and the criminal justice system for their existence. And to the extent that they might hear from a major referral source that, we're not going to be able to send you clients if you can't offer the treatments that experts who treat this condition say needs to be available. If they get a very clear message from you that you want to see them do it, it may help.
And I appreciate that. I guess my next follow-up question is, how do we get them to communicate that outcomes with us? Because we run into CF-42, we run into all of those confidentiality rules. Even though we have a drug court, I mean, we still get stonewalled a lot. And
you have a lot of power in that situation, because if drug courts work a little differently, but for a patient to complete a drug court program, which might mean having charges dropped, or the patient should be able to consent to having anything shared. And I think you're able to make that a requirement if they're going to, if their option is jail or treatment court. Treatment court can mean that they're giving permission for all of their records to be shared.
can you come to my county?
So turning to the phones and following up on that, a question about your experience or your thoughts on initiating medication-assisted treatment when people are incarcerated. Is this a good time to initiate treatment, or a good time to work on people's addiction, and how have you seen that roll out successfully?
So I think that the argument against using, say, buprenorphine or methadone for people who are in prison is that, hey, they're in prison, why do we have to give them buprenorphine or methadone if they're not out in the community? And they're all abstinent because they're in prison. And that's kind of silly because drugs get into prisons very easily, and patients overdose in jails and prisons where drugs have gotten in, just like they overdose in rehabs sometimes. So I think that if someone's been admitted to, is in jail or prison, we should be treating their condition with, their health problems should be treated appropriately, and their addiction should be treated appropriately, and they should be getting buprenorphine or methadone if it's appropriate for them. New York City has a long history of offering methadone maintenance on Rikers Island. It's called the KEEP program, and at Rikers Island we have both a jail and prison. Jail is where people await sentencing or serve a short term, and their prisons. And if they were in the prison part, they didn't get to stay on their methadone. But for people who were in the Rikers jail, which could be up to a year, they've been maintained with methadone with good success, and then sent out the door on methadone, and more recently buprenorphine, and with some good success there as well. So there are prisons and jails that are doing this, but very few.
Another question, this one from Santa Rosa. Do you see an analogy between the willingness of the country to respond to opioids as an illness, an analogy between that and the response that the country made to HIV when it began to move out of communities of color and out of just gay men and into a broader community? You made that analogy earlier about a slide of HIV and a slide of the opioid crisis. And any thoughts on that and how we treat it as an illness for everybody and not only for certain populations?
I think that there are many parallels. if you think about the way Ronald Reagan responded to the AIDS epidemic, or actually the way he didn't respond to the AIDS epidemic, Ronald Reagan really ignored the AIDS epidemic until very late in his presidency. He wouldn't speak publicly. He wouldn't say AIDS in public till I think maybe his last year in office was the first time he would ever speak about it. And the reason that he wouldn't speak about AIDS, I think, is I think most people would think that it was because you had a disease affecting gay men and intravenous drug users and highly stigmatized groups. And many people believe, I believe, that had Ronald Reagan been spoken about it, not just got his administration to be more active early on, but had he also been speaking about it earlier on, that we might have been able to prevent many people from ultimately contracting HIV and dying of AIDS. So there's a real failure there. If you think about President Obama's response to our opioid addiction epidemic, I think the President Obama in many ways was as bad on the opioid addiction epidemic as Ronald Reagan was on the AIDS epidemic. For the first 7 years of President Obama's presidency, he never once spoke about the opioid addiction epidemic, and he never sought any funding in his proposed budget to Congress for the opioid addiction epidemic. And if anything, there were some decreases in funding to SAMHSA and to NIDA. CDC was one agency that was spending money, but they were closing out programs and shifting money to make it available. I would say that President Obama has made a very sharp turn in the past year. So he went from completely neglecting the problem to now finally speaking about it quite a bit. So a year ago, he spoke for the first time to a live audience he went to West Virginia, spoke to a group about the opioid crisis. During the State of the Union, the first sentence of the State of the Union speech this year addressed the opioid addiction epidemic. He spoke at a conference, and more importantly, he's now seeking funding from Congress. He's seeking $1.1 billion in new mandatory funding for the opioid addiction epidemic, and very, very late in the game, and way later than where we were with HIV, because with AIDS, certainly within 10 years, the AIDS epidemic began in 1980, within 10 years there was quite a bit of federal money already moving in. Here we haven't had one real increase in funding for the opioid crisis. Now the president's seeking $1.1 billion, but Congress, and the Republican majority in Congress, does not has been blocking the president's request for funding. I think in part there may be just politically there are people who believe that we shouldn't spend any money on a social or health problem. But what I think is going on is that what we're seeing in Washington is partisan politics, not wanting to give the president a win on the opioid problem by approving his budget requests. So you have members of Congress who are home now campaigning campaigning on the fact that they helped pass CARA, which is said to be a comprehensive addiction recovery act. It's not a comprehensive bill. It's aside from allowing NPs and PAs to become eligible to prescribe buprenorphine, which is the one really good thing in the bill, much of it is useless without funding. So we still have a long way to go. But I think the parallels between our failure to respond to the AIDS epidemic because of the stigma of intravenous drug users and homophobia, I think that with our opioid addiction epidemic, had it been any other medical condition killing so many people, we would have seen a much more proactive response from policymakers.
I think we have time for just this last question.
Hi, Hi, my name is Christine Sippel, and I'm from Santa Cruz County with a multi-service nonprofit that includes alcohol and drug treatment programs. And my question is if you've seen across the nation and other states more progress in integrating reimbursement sources, really, and structure of SUD treatment programs so that they can include the primary care needed to prescribe and integrate MAT into SUD programs. Our drug Medi-Cal, I don't see allows us to do that.
I don't know if there are any states that have totally nailed it. Vermont has a hub and spoke model, which involves working with primary care for medication-assisted treatment, basically buprenorphine. So it's getting patients inducted and stabilized in the hub, and then farming them out to the spokes to be maintained on buprenorphine. But they've really struggled there with access to prescribers. Many of the prescribers in Vermont who've been doing this have been at their cap on the number of patients that they can treat with buprenorphine. The cap just got lifted, which I think is going to help, and maybe that will make a difference. So I'm not sure, though, if there are any really good models out there where we could say, this is what every state should be doing. I think everywhere we're really still struggling.
Thank you all very much here in Oakland and other places for coming. I wanted to note that Dr. Kolodny's slides from this morning's presentation, which a number of you have asked about, will be available, and we'll let you know how to access those. And we will also have a summary of these questions and discussion for all the sessions that you'll be able to see. So please join me in thanking Dr. Kolodny for this conversation.
Thank you.